Anyways, pneumonia prevention, that is what we are going to discuss. And for that, I am very happy to have a wonderful panel of experts over here. And definitely, we know when we are talking about prevention, it is not only the vaccination. It is so many things comes into the package. And that's what we are going to highlight is pneumonia prevention I am talking about, not a pneumococcal pneumonia or something very specific. So pneumonia prevention, yes, most important thing is appropriate case management, and that's what we since morning we have been discussing how to manage best way our case. That is about one thing. Second thing is we know that nutrition and hygiene practice is very important for pneumonia prevention, and here exclusive breastfeeding, a single most factor that can help your kids a lot. That's exclusive breastfeeding for first 6 months and a balanced diet, because we don't want a malnutrition, we don't want undernourished children. That's why balanced diet is important. At the same time, we need to reduce the risk factors, and most common risk factors are the environmental one. We know that they are crowding, we can't do much about it, but at least indoor air pollutions, tobacco smoking, like cigarette smoking, and this so much of congested people, the surrounding is one of the factors. So we need to take care of that risk factors also. And lastly, we have certain vaccines. If we have not given, say, measles vaccine, that's very important. That itself can cause a pneumonia. The child is more liable to get a pneumonia. So we have certain diseases, vaccine preventable diseases, which we have to give importance to prevent the pneumonia, because pneumonia is not only one organism, but what we have in our armamentarium is pneumococcal conjugate vaccines. We have influenza vaccine. We have something coming up for the RSV also. That's not typically it is vaccine, but it's a monoclonal antibody. We're not going to discuss much about it, but I can just tell you that RSV vaccines is available, which is for either a pregnant woman, which will be given 30 to 36 weeks of pregnancy, which will take care of the newborn, like infant, and you have for old age patients, maybe more than 75 years of age, and in high risk condition between 50 to 75 years of age. That is RSV vaccine. Otherwise, we have monoclonal antibodies. There are two brands which is available. One brand which is going to be already available. There, the monoclonal antibody is to be given every month for 5 months during the influenza series. And there is one more which is coming, a single dose monoclonal antibody, which has to be given just before the season in the newborn to prevent that RSV pneumonia. And lastly, as I said, measles are very important, and at the same time pertussis. So these are the vaccines which are important as far as the pneumonia prevention is concerned. Now, if we see estimated burden of the disease, we have a huge burden, 3.6 million episodes of severe pneumonia and 0.35 million pneumonia deaths occurring less than 5 years. Mind well, that's the reason we are more concentrating in less than 5 years of age group. Estimated severe pneumococcal pneumonia, these are the figures for severe pneumococcal pneumonia, is almost 0.56 million, and 105,000 pneumococcal pneumonia deaths, they are occurring in less than 5 years of age. Now, when we just discussed what are the major contributors to pneumonia, Streptococcus pneumoniae scores, as we discussed, whatever age you take, Streptococcus pneumoniae is going to be a very important pathogen. We need to take care of that. At the same time, H influenza, RSV, and influenza itself, it can cause the pneumonia. So when you talk about this incidence, estimated incidence of severe pneumonia, which if you say between, say, up to 5 years, it is 30 per 1,000 children. When we talk about less than 1 year, it is 87 per 1,000. So that's why younger the child, more chances of severe pneumonia and complication and deaths to the become. That's why we, reiterate that we need to start the children protecting as early as possible whenever the vaccines are available to be given a recommended age. So Streptococcus pneumoniae, it's a leading cause of pneumonia deaths. 52% of all fatal pneumonias, they have been in children. This is the data of 2016. Strep pneumonia accounts for 11% of deaths in under 5. Okay, and antimicrobial resistance. Now we have been talking more about antibiotic stewardship. So antimicrobial resistant serotypes in pneumococci are gradually evolving. So that's why it is very important to take care of this particular pathogen, and that's why we are here, because the pneumonia conclave is been ultimately based on the pathogens which are creating this pneumonia. Okay, so we have many vaccines. We know that pneumococcal conjugate vaccines, we had 2 vaccines like PCV10 and PCV13, which were there since long, and then there are 2 more options which came to market, PCV10 new, that is Pneumocil, and PCV14, that is Vivax. Now, we will be discussing first pneumococcal conjugate vaccines. So basic information we should be knowing that yes, we had these 4 vaccines. Okay, what are the differences on this? If you can see this older PCV that is in Florix, that was missing out on 3, 6A and 19A serotypes. When you consider newer vaccine, that is newer PCV10, that is Pneumocil, it is missing out on 3, 4 and 18C. Yes, it is taking 6A, which was not there in Synflorix. Okay, now you look at this PCV13. They have 13 serotypes, including 3, 4, 6A, 19A all. And now we have one more vaccine, that is PCV14, that Pneumovax, that is having all this 13 minus 6A plus 22F and 33F. So this is as the numbers and the serotypes which have been many times which have been highlighting. Now we'll have to go into the crux of it. What exactly matters as far as the pneumonia prevention is concerned. Okay, so now if we go a bit deeper, I can tell you that these 4 particular vaccines, we have different antigenic contents. If you can compare that GSK brand, that older PCV, you see that antigenic containing 3, 1, 1, 1, 1 like that. If you see the PCV13, it is having 2.2. So they are having some difference in antigenic contents also. Not only that, they have different serotypes, different antigenic contents, and lastly conjugation technique and protein. There are certain vaccines, suppose we have the Pneumocil and Prevnar 13, that is having the same conjugation protein. But if you see older PCV, that's Synflorix, that's a different conjugation protein, TT. So that's the difference of this all available pneumococcal conjugate vaccines. Now, whenever you discuss or see any presentation on pneumococcal vaccines, you will be finding this kind of charts. Now, this is an original chart which is not having any caveats. So these are all different studies which have been done, and they tried to figure out what all serotypes were found in that study which are present in available PCV vaccines, right? So either it is a PCV10 of Synflorix or a Pneumocil or Pneumovax or a Prevnar. So this is, so when you see certain discussion, they might say because serotype 3 is not working, we'll discount it and then we'll project the graph, right? Suppose you get, there will be graph which will be showing 6A, it is getting cross protect against with 6B. That's why let us consider 6A is also covered. No, this is not without, this chart is without caveat. That this is the study, and you know that these studies are not been done in the same population at the same time in the same inclusion and exclusion criteria. So you should have some average. But mind well, this is not the efficacy or immunogenicity or something very specific, but this is just, you are getting that these are the serotypes which were found and these are the serotypes which were present in particular vaccine. So if you see that Prevnar 13 is having almost 78% of these serotypes which have been covered. And rest is, suppose Twinkler is 67%, PCV10 73% and PCV14 74.8%. So this is in general your serotype coverage with whatever available PCVs. Now let us go to the discussion part, and first I would like to go with Dr. Jaideep. We have taken a huge advantage of him being here for the beginning of the year and ending the year also. So I'll start with you. Your controversy or consensus? 6A, always we have been telling that something is that there are 2 vaccines which are having 6A, 2 they are not having 6A. Now how will you sort it out?
I would like to ask you one question. Why did you have this CA seminar like this? Why not online? Of course, it has its advantage. You know, we are interacting directly. We are interacting. You are asking question. We are. It's a much better vibe. So that online CME was a fallout of COVID. It was just a substitute. It's the same thing. 6B protecting 6A is just like a something surrogate. So now, if you see the development, initially PCV7 was launched. Now, after launch of PCV7, certain things came out that there are certain serotypes which were increasing and certain serotype which needed to be covered. And that's how PCV13 came, and that's how the older PCV10 also came out. Now, mind you, all these PCVs are actually not 13, not a single vaccine. It's a combination of 13 different types of vaccines. So people started playing with some serotypes. Why not we ignore one serotype, include others? Yes, there were cross protection from 6B, but it was also revealed that 6A incidence increased in most of the studies. And that's why it has been conclusively proved that 6A is an important serotype. As you can see here, 17% of the isolates are 6A. And for that 17%, we cannot depend entirely on 6B that it will give some protection. So direct protection is of course better than indirect protection. That has been already told in all the publication, in all the discussion. So there is no controversy. We need a protection from 6B, from 6A, and 6B gives an inadequate protection. So whatever comes of PCV without 6A is a bit handicapped. And if we see what's in the pipeline, the vaccines which are coming, the more valent PCVs all contain 6A. So 6A is one which cannot be ignored.
So friends, we understood that because we have different PCVs. This is not only 4, they are coming, next 4 or 5 coming more. They have some difference. So you know that there is always not a need of the disease. Yes, definitely, because they see that there may be a serotype replacement, because they tried to first cover with 7, then they increased to 10 or 13. So there is some serotype which are coming up, that is serotype replacement. And there are certain serotypes which have been coming up because others have been controlled. So there is new emerging serotype. So there is science behind. But we know that one PCV cannot be same like second PCV. So there is some patent issue. So either it has to change the serotype, has to change the conjugation, either to change the conjugation protein. So there are so many things which should be considered. Okay, now Dr. Jaideep said that yes, 6A is very important. Okay, we have 6A, but there is a vaccine which is having say certain 4 and 18C is been missing, and southern vaccine which have been adding 22F and 23F, 33F, sorry for my this thing. Nishal, Dr. Nishal, does these add any value or it's just a juggler of numbers?
We know that the pneumococcal have more than 100 serotypes, out of which around 20-25 are more common causes infection in human being, more common invasive pneumococcal diseases. And we have been seeing that when initially it was PCV7 available, as Dr. Chaitanya has already said, there is a serotype replacement. Newer serotypes are emerging and causes more invasive pneumococcal disease in children as well as in adults. So this is definitely not the jugglery of numbers, but this presence is very, very important, and that is why the vaccine manufacturer or vaccine inventor is going from PCV 7 to 13 and now going to PCV 20. So these numbers are very, very important. But as it has been said by Dr. Jaideep, this is 13 various or 14 various antigens in one vaccine. So it again becomes very difficult to increase the number of serotypes into it. So there is a caveat in which how many you can add. So there are few things which is going on in the research and development, but these are very, very important serotypes, and it causes lot of outbreaks in cases of invasive pneumococcal disease in children also.
So when we talk about certain serotypes which are not there in the vaccine, and then we know that this is ultimately a commercial market where many things come into play. We know that certain serotypes, even if the numbers are less, they have been removed. That means definitely there is going to be less protection against that particular serotype. Now whether these serotypes numbers are big number or less number in your country or in area is very important. Now the problem with us is data is very limited. Still, because of this availability of PCVs, the data are coming up, because there is ultimately funding comes from pharma company, and then ultimately we are getting more and more studies. So we need to have our own data where we can see, yes, these are the serotypes which are more common. That's why if you add on, there will be some advantage, or if you miss it out, you may be having some disadvantage. So that's why this 418C, according to whatever the literature, they are amongst the outbreak serotypes. They are been invasive, but they are infrequently found. Okay, in the carrier study only. So this is been included since beginning of this PCV era, that is PCV 7. So definitely these are the important numbers, may vary. Okay, now pneumococcus pathogenesis, I thought Dr. Subbu will cover everything, but I think for common pediatrician, he didn't cover. So this is simply you get the organism in the throat, it goes to the neighboring area, then it will be causing a non-invasive pneumonia, okay, because it is ultimately traveling directly. But if it enters the blood, it causes bacteremia, and from there it goes to some places, it is invasive. So this is basic difference between invasive pneumococcal disease and non-invasive pneumococcal disease. So if it is a mucosal spread, it will go to ear, otitis media. If it goes to lungs directly, it can be a non-invasive. Whatever we are talking is an invasive pneumococcal disease, and ultimately, so if you can have invasive and non-invasive, pneumonia per se can have both mucosal spread as well as through the blood. And that's why people were highlighting, yes, you should be going for blood culture in the case of pneumonia, because bacteremia, if you can find, you can be very sure this Streptococcus pneumoniae is a culprit. Okay, fine. Tushar, Dr. Tushar, are we targeting IPD? As I said that invasive pneumococcal disease, what is it? So are we targeting only invasive disease? Because with this, I know that PCV has been, for IPD only. So should we be thinking that only?
So definitely we are targeting IPD because what we are worried about is under 5 mortality, and when we look at a larger level or a mass level issues, the program should be targeting at that level. But at individual level, we know that it is not just IPD but even non-invasive, even looking at like what the whole thing spectrum of the disease, we know that from asymptomatic nasopharyngeal carriage to otitis media and pneumonia, which are non-invasive also, are important. So when you look at the overall prevalence and the base of the pyramid, you know that there is a huge prevalence which is almost 100x more than the IPDs, which also is responsible for pneumococcal disease. And when you look at prevention of disease, you look at in the wholesome way. So definitely everything is important.
So if you want to prevent pneumonia, definitely you will try to concentrate more on meningitis or bacteremia or pneumonias, but we should be starting from nasopharyngeal carriage itself. Because if we can eradicate from there, definitely we may not need further things. But whenever we are talking about vaccine, it ultimately it will try to cover morbidity and mortality. The mortality is first. And we know that mortality is more because of the invasive pneumococcal disease. And that's why we are talking more of invasive pneumococcal disease. But if we get along with invasive pneumococcal disease also the mucosal protection or a non-invasive pneumococcal disease protection, that's also very beneficial. Okay. So that is what Dr. Tushar wanted to highlight. Okay, fine. Now, so that's where I can say this 13 serotype in whichever PCV 13, because PCV 13 is been considered a bit gold standard, because everything is been considered or compared with this particular vaccine. So they are having the serotypes which may cause invasive pneumococcal, as well as there can be some serotypes they can cause pneumonia more, otitis more, mortality is more, antimicrobial resistance. So we will be having a a broader approach to have all-inclusive things, and we should be concentrating on that. So if you see this PCV 13, it helps to protect against IPD 86%. It really reduce the pediatric emergency room disease like visits for alveolar CAP, community acquired pneumonia. 53% reduction in ambulatory care visits for otitis media. Now we know that otitis media is not going to be that serious, but that will keep the patient coming to you frequently. So the OPD visit will be more, and many times we know that we hardly do the otoscopy, which we should be doing. We should be diagnosing, rather we should be following up with the otoscopy, and they should be treating it properly. So that's why it requires, if we can prevent it, it's good. So now the question comes that we have so many PCV vaccines. Somebody has given some vaccines, and even government patient is coming from NIP to SA wave. That scenario we are going to discuss. Dr. Unmesh, can we use it interchangeability? Is there any data or what you practice in your day-to-day office practice?
Ideally, interchangeability is not advisable.
Why? My question is why?
We have limited data about
Correct.
Interchangeability, and second, each PCV has some difference in serotype.
Correct.
And second thing, they have different preservatives and dose. Those also, some serotype are different in different PCV. So if we give, then it will affect the immunogenicity and also on impact on disease also affect. So that's why not.
So very important point he's brought out is that absence of data. There is no studies which have been said that first you give this vaccine, then you follow it with that. There are data for Synflorix and Prevnar. If you have given in primary series the Synflorix, and if you give booster dose of Prevnar previously, it is allowed because incremental value is there. So that is the only study. Otherwise, there is no much study. So whatever you do is not by your choice, but it's by your compulsion. So if you don't know the details, what has been available, or it has been given and person doesn't want to go back to that, say, government setup. If you want, then you can go for the options available, and incremental value and the data which has been supporting us should be considered when you are choosing the switch over the PCVs. Okay, few technical queries, Dr. Jaydeep. Who else can be answering it better? Do you give importance to product label? That means, whenever we are talking about certain vaccines, no, we say it's off-label use. Okay. So what is that product label? And do you know what anything specific about that product label which can really affect our routine use of vaccines?
Is the second question also to me?
That is also important because we have seen that whenever new vaccine come into market, it has to establish a non-inferiority to existing brand in an existing schedule in an existing dose. Right. So that is called non-inferiority trial. Now everybody says it is proved non-inferior to existing brand. But what is that non-inferiority? So if you can take both.
Yeah, I will take the second first and then
Okay.
I will come to the first. Now, non-inferiority, actually whenever a clinical trial is done, there is one arm, there should be the drug or the vaccine concerned, and the other arm should be control or placebo. Now, because there was already an existing pneumococcal vaccine to start with PCV7, then PCV13, so we cannot do a study with a placebo or a control without PCV, because that is ethically not acceptable.
Correct.
So the benchmark is an established conjugate pneumococcal vaccine, PCV7 initially, now PCV13. That's the benchmark. So while we study some newer PCV, the comparison is with an established PCV to prove its non-inferiority to the existing PCV. Point is that the serotype which are not there in the existing PCV, like 13 was studied compared to 7, then the rest of the PCVs are calculated as per the WHO specification of 0.35 microgram per ml IgG. So this is non-inferiority study. That means whichever PCVs we are studying now should be in comparison with an established PCV. This is non-inferiority. Now, coming to the first question, as per the licensure criteria of DCGI, any PCV when studied in India for the first time should be in 2+1 schedule. That means 6 weeks, 14 weeks, 9 months booster. Because that's the schedule followed by Government of India for routine immunization. So any PCV for licensure, they have to comply with this and initially study on this. Point is that as per the recommendation of ACVIP and also any other international bodies, we need a toddler booster of PCV. So here comes the interplay. Say for example, the newer PCV10, they have a toddler booster study in the Gambia, which is published. There it shows that yes, a booster in the second year of life is effective. That is why in their product insert, it is given that this PCV10 can be given at 6 weeks, 10 weeks, 14 weeks, either 1 or 2 doses with a third dose or a fourth dose if required is the term at 9 to 10 months or at 12 to 15 months. Now this is the catch, because it is not very clear. As per the recommendation of ACVIP and other ACIP and others, it is 3+1 dose. But here the catch, because this study is not yet in India. Secondly, the PCV14. PCV14 as of now, the studies is only as the primary series, 6, 10, 14 weeks. The booster study has not been published. So these few things are very important to see in their product insert, and let us not get misguided, because if we want to follow the guidelines properly as a private practitioner, because when a parent brings their children to us, they want the best protection for them. because they are coming to a private practitioner. So as for best protection, we are bound to give that 3+1 schedule with a booster in the second year of life. So we can only go for that with an established vaccine which has got trials and publications with a 3+1, rather than going some misguiding information that may be in some product itself.
Dr. Tushar, you want to add
Yeah,
something?
a small clarification which I think maybe we can discuss. As far as I know, and maybe I'm subject to this thing, that for non-inferiority trial, if the serotypes are not there in the control vaccine, you will do it with the smallest or the lowest serotype in the vaccine and not 0.35 of WHO guidelines.
So-
And second is, when you are using a product which is off-label, more than anything, it's a medico-legal issue. So if there are some issues, maybe when they are challenged because of whatever issues that happen, usually these vaccines are quite safe. But then for whatever reason there is a problem, it may come on to our head. So it's better always to use as per the label rather than off-label. Or if there is an ACVIP recommendation which is going beyond the label, then also it's fine, because you need to have some evidence to say that why you have done what you have done.
So let me just simplify the things. WHO said whenever new vaccine comes into market, it tries to show that the immunogenicity or the antibody titer, IgG antibody titer, should be more than 0.35 microgram per ml for invasive pneumococcal disease. That should be collective, not individual serotypes should be performing more than 0.35 microgram per ml. Now this is for invasive pneumococcal disease. When you are talking about mucosal disease, you need a higher concentration of antibody. That is one thing. Second thing, they said that you can have a serotype specific geometrical mean titer ratio, and that should be a higher as compared to if you just show that it has been double or double fold. No, that is not that. So you need to have these particular criteria, and because the government of India is not recommending any booster in a second year of life, these companies or new brand, they are not been compelled to do the study of the booster, because they are giving 2+1, and that's why the third dose which are given at 9 months is a booster dose. So now let us go ahead. Now again there is some technical glitch. OPA titers is a functional antibody titers. IgG, which is important, which is better than other, or both are important.
Yeah,
Tushar.
so as like we have heard these labels of IgG, there is ELISA titers and OPA titers in many of PCV lectures now, and many of us know and understand that when we look at the ELISA titers or IgG, we know that they are basically your GMCs, which are, as very rightly discussed also, that if total overall aggregate of all the serotypes is more than 0.35 IU per ml, then we know that yeah, it's a correlate of protection, and it gives an approval for the use of this vaccine in the field. Whereas OPA titer, the advantage is it's a functional antibody titer, which gives us the it's a surrogate marker of a functional that how much opsonization is possible basically by these antibodies which are against various serotypes. So therefore there is a definite advantage of having a OPA titer, but and that is by GMT. So like 1 in 8 is the minimum dilution, which they say is going to give a clinical correlate that yes, it is having an adequate functional titers. So both are important, and when it comes to specific things, we know that when you look at various serotypes and their individual IgG titers and various OPA titers of individual serotypes, they may be subnormal, but as far as approval is concerned or WHO criteria are concerned, they say that collectively if it is more than 0.35, you don't need to look at individual IgG and OPAs for approval purpose. But in the long run, definitely those who have better titers or better OPA titers are definitely much better serotype protection as compared to the ones which don't have.
So the licensing is a different ball game, and individual protection is different ball game. The DCGI will give approval according to reports on the studies. Suppose we know that the one of the brand of JE vaccine, it is been recommended by DCGI single dose, right, Genvac. But nobody none of India, our National Immunization Schedule or ACVIP, they said you have to give 2 doses. It's like that. Approval will come by this data or the study. So so both the things are important, but in general when you see, you have to look at the whole things as a whole. Now, Nishal, Why and what is the difference between NIP and ACVIP? Now, this is always going to be a struggle for us to understand.
So NIP is for the mass public health importance, whereas ACVIP, what he directs is definitely for mass, but for individual protection. This difference is very, very common. So whatever vaccines come in the national immunization program, the cost benefit ratio becomes very, very important, number one. Number two, they will have to match with the current immunization schedule into them, so that in national immunization program the PCV is given as 6 weeks, 14 weeks and 9 months, 2+1 schedule, so that the child comes to the institute and take the vaccine during that time. They don't have to come extra for this reason. But in an individual protection practice, we need to follow 3+1, that is 6 weeks, 10 weeks, 14 weeks, and a booster which is in a toddler age. So this is the basic difference between us. And when we are giving it in a private practice, a licensed label vaccine which is allowed to be given as 3+1 schedule, ideally we should be following that, and that is very, very important to follow in individual practice.
Very well said. Now, there is a difference. NIP, it is giving 2+1. So what happens? They are giving 6 weeks, 14 weeks, and there is a gap. Then it's 9 months. So if you compare head to head, do both the schedules, you have a gap between primary series, NIP, and a booster between 9 months. There are few serotypes, 6B and 23F. They may be undercovered rather during this particular time. But when you give that booster, ultimately it covers same. So your 3+1 seroconversion wise is at par with 2+1 when it is completed. Okay, so then seroconversion wise. But we know that antibody titers matter, because we discussed that invasive pneumococcal disease you need 0.35 microgram per ml. But for mucosal you need higher. So higher antibody titer which is lasting longer is important, because in second year we know serotype 1 is very common. Yes, so if we want to cover, we have to have antibody titer to cover. That's why we are giving in second year. So for individual protection, it is 3+1 which is better. For mass, it is 2+1. See, in UK, they started with this reducing number of dose because they had PCV7 in the circulation since the beginning. So then they made it 2+1. Now they are going for 1+1 also. So because their coverage is good, maybe our country, if its coverage is good, then they may go. But as of now, individual protection 3+1 is important. Now this interesting scenarios. Yeah,
I add one thing. 2+1 schedule why choose by government? Because there is a under 2 mortality rate of IPD is high in children under 2 years. So 2+1 schedule, when we give boosters at 9 months, there is a high titer in second year of life. So
correct. That's what I told. 2+1 is equal to 3+1 once we have completed the booster series. Okay, fine. 14. Now this is a real scenario. I think I have 2 minutes, but let me try to take 5 minutes more from your time, because your lunch will start after 2 minutes. Okay. You have to be back by 2 o'clock. So you can decide if we can continue for 5 minutes more. 14 weeks old infant brought for the third dose of vaccination with previous 2 doses, 6 weeks and 10 weeks in national immunization schedule. We know that in 6 to 10 weeks, what is that? We are giving fractional dose IPV. We give pneumococcal conjugate vaccine for 6 weeks, not for 10 weeks. Okay. And we are giving OPV along with that. Now, Unmesh, what will you do next?
I will give.
So let us go to a very clear question. How many PCV you will give?
PCV 2. More 2 is PCV.
So
PCV,
you will give, see, patient is at 14 weeks. You will give 1 PCV now.
And
then
third dose I will give after 2 months.
After 2 months?
After 14 weeks, they give in government 2 months gap.
Okay.
First.
So you want to give 1 more dose after 2 months. You want to give 1 more dose, then you want series to be over.
No, 3+1. I follow.
Okay, fine. Anyone else who wants to
So
change
if
the
a
schedule?
child is coming at 14 weeks, I'll give 1 dose now and a booster at a toddler age. Total 2.
Then it will be 2+1 only.
The third dose.
This is only, he has written only 1 PCV in 6 weeks.
No, two more.
See, birth.
In private practice, we give 3+1. So only in government first dose given at 6 weeks.
10 weeks they are not giving.
So second dose I will give second dose,
Haan.
and third dose I will give after 2 months.
Why 2 months? 1 month.
Okay, okay. Now let me make the
I
things.
follow the 2 for 6 month, which is better.
No. Okay, okay, fine. So let me clear the thing because we have lot less time. So we will give one dose now. So that will make your second dose. Now we want to see if the patient is going at 9 months to government setup, fine. Right? But if we want to continue our setup, we'll give one more dose after 4 weeks. That will make 3 doses and 4 doses in the booster in the second year. Okay? So that is very clear about PCV. Okay, fine. So that is what I told. Now only fractional IPV is given at 6 weeks. 14 weeks, what we have to give either because standalone IPV is not available. Now what will you do? Will you give hexavalent vaccine?
Hexavalent vaccine.
Then it will be 2 dose only IPV. Then what will you do?
Then standalone IPV is not available. So booster only option at 1.5 year.
So we will wait till 1.5 years? Or can you give it early?
Or
Jaideep,
other
you have any
option-
solution for this?
It can be given beyond 1 year.
Yes. So the thing is, primary and booster series, between that minimum you have to have a 6 weeks, 6 months. So you can make it that second year booster at 12 months. So you can make it a bit early. That's an option because we don't have a standalone IP
See,
available.
more than 3 DPT in the first year is not recommended. So
Yes.
we will stop at 3 DPT in the first year, and the booster may be preponed from 18 months to beyond 1 year.
Yes. So here we will not go for one more IPV containing vaccine because we have pentavalent or hexavalent. Okay, fine. Scenario 2, 6-month-old infant brought with flu for the flu vaccination in primary series done at NIP. Now if they wish to shift to private sector, how will you manage, Dr. Jaideep?
See, now
Again the same question
Yeah.
for PCV and IPV.
Yeah, I think regarding IPV, it's already answered.
Ah.
Regarding IPV, so this is the only. Regarding PCV, for better mucosal protection, we will go with 3 PCV in the first year and a toddler booster. So,
Give one more piece.
yeah, give one more PCV, then give a booster in the second year.
So either you can go for give me one more PCV and go for second year booster, or you can send them to government. So that's the second option.
Yeah.
Okay. One for IPV, we discussed that you can send him to that 9 months this thing booster, and then you can give it one PCV IPV containing vaccine earlier. Okay. Nishal, infant after primary immunization at NIP comes at 9 months. What will you do?
So after the 2018 impact, we have studied that we should not miss any opportunity to vaccinate. So whatever is required at this age, like 9 months MMR is important, then definitely the influenza vaccine which has not been given should be given. Typhoid conjugate vaccine also should be added, and as the child has taken already 2 doses of pneumococcal vaccine at 6 weeks and 14 weeks, we will definitely can offer one more PCV right now so that the course is completed. So 4 injections at a time can definitely given to this child when it comes to us in our private practice.
Correct. So now the infant who has received all NIP vaccine till 1 year of age, okay, now comes at 16 months. What about PCV booster and IPV? I think we have discussed, but still reiterate, Dr. Tuchar.
So child has completed the schedule as far as PCV and IPV is concerned, and like second booster for IPV you would give at 4.5 years as tetravalent vaccine or whatever way. But so you want, because you know that there are falling titers for polio, and therefore you want to give as IPV combo vaccine as second booster. As far as PCV is concerned, there is no recommendation of giving extra dose because this is done. So your protection is over.
Jaideep, you want to agree or disagree or?
No, you have mentioned NIP till 1 year. So 1.5 year booster, I can give one IPV containing, number 1. Number 2, regarding the PCV, government is not giving PCV 13. So PCV 13 has got, I mean, the more serotypes, containing more serotype containing vaccines. So for in the toddler series, we can give one.
That may be overdoing.
This is
but
like somebody has
recommendation
taken
says-
Gardasil 4, would you give Gardasil 9?
Yes,
Yes.
because extra coverage of extra serotype, because as the age advances, even fewer dose of PCVs are also accepted.
Again, it is off label.
But again, it is a controversial because
recommendation.
government has now switched to PCV 14 now, so we don't know what to do in this situation.
So that will be discussed in next thing. The 20-month-old infant who has received all vaccine in NIP till 18 months. Now what will be your advice?
For PCV, ideally 2+1 and 3+1.
Same.
After booster dose, both are comparable antibody titer. So not
So
required.
suppose the child has not received PCV and comes at 18 months, what will you offer? Which vaccine? Which brand?
PCV 13.
13 can be given, okay? 10 can be given.
Two dose 8.
Even newer 10 recommendation is there.
Synflorix recommendation is also.
So we have all options. But suppose the patient comes after 2 years, between 2 to 5 years. What are the options?
Only PCV 13.
No. You can
There are
give
two options if the child comes after 2 years,
PCV
which is the
13.
GSK's PCV and Previnar. But the only thing that Previnar you can give a single dose, whereas for GSK's PCV you have to give 1+1, 2 doses.
Okay. Now, Jaideep, we are not getting 1.5 years booster HIV containing vaccine. You can take whosoever. What will you do about HIB?
See, this is very difficult because standalone HIB is not available. So we cannot give HIB like that. Off label, what you can do is that GSK containing hexavalent vaccine HIB comes separately, but then also the diluent issue is there. When Hiberix was available, then the diluent was normal saline. So we can dilute this HIB with normal saline, but definitely with prior information to the parents and give it off label. But otherwise, there is no other option.
What is doing and overdoing? There has to be some difference between these two. Anyways, now let us go to a very important question. What about adult immunization, adult vaccination? Because we know we have Dr. Tushar and Dr. Tischel both have been practicing more towards the grown-up kids. Can you just throw light about all these three questions?
So adults definitely need vaccine, we know that, and in US like CDC and other places they are doing lot of work and they are trying to involve pediatricians to help them to conduct adult vaccination and create awareness for this. Even I would recommend that all of us as pediatricians, because we are the torchbearers in this field of vaccinology, I see that physicians or even those subspecialty experts are also having a laid back attitude in actually advocating vaccines whenever it is recommended. So we know that adults above 50, because they have some immunosenescence, and under 50 who have comorbidity, as whatever diseases that we can discuss, have a huge need for at least PCV prevention. We know that there is a huge morbidity, and not only morbidity, but even more mortality than a younger age as far as elderly people are concerned who are above 65. So we must recommend PCV vaccine, flu vaccine, and so many others which are adult vaccines, but we are focusing on PCV today. And as healthcare professionals, we all, including our staff, also need this PCV protection. So definitely it's important. The recommendation for 50 and above is a single dose for PCV 13. And if somebody is having comorbidity or high risk, then a PPSV 23, which is a polysaccharide vaccine, as maybe 6 months to 12 months after the PCV as single dose. And if there is a continued immunosuppression or something, then one more dose after 5 years of the first, but not more than 2 doses of PPSV 23.
Now, Nishchal, I have a cousin who has been visiting to India. He has received PCV 20, which is available in international market. Now, will you offer that one more PPSV 23, PCV 13? What will be?
No. It is not recommended if one has taken PCV 20 as an adult immunization. One. Second, for even more than 50, PCV 13 single dose and PPSV 23 after 1 year. And if the person is less than 65 years, one more dose after 5 years. This is the routine recommendation. I like to add something in last answer. Counseling, and the counseling is the choice. Saksham counselor, a counselor sitting outside of your chamber, is very important to talk each and every parent about adult immunization. We should create creatives, increase awareness about this. The most important thing is we and the staff, if we have taken, we are more confident of talking about adult vaccination to our parents. So that will add lot of value. So implementation is tracking of the patient, informing them repeatedly, and inviting them for vaccination is very, very critical.
So when you decide about adult immunization, we should be looking at this chart. You have incidence of streptococcal pneumonia higher in the younger age group and more than 50. So look at the chart. So that means you need to have there initially when you don't have immunity, and later age when the immunity goes down or immunosenescence comes. Okay, so Dr. Naveen Thakur want to say a comment, please.
It's a very interesting discussion, and I really compliment that you are trying to harmonize between NIP and ACVIP. So, see, when we talk about NIP, it's about public health, and it's what is good for everybody. When we talk about ACVIP, we have to see what is the best, even 1% better for the individual child in our office practice. But what care we should, we should be very careful not criticizing that, because
Correct.
masses will get that, and there is enough evidence. You will see many more and more. HPV will come in one dose. We have MR versus MMR.
Yes.
We have OPV versus IPV. So never criticize, and this is a very good way to do that. If he is interested, he says, I want to complete here. You just give as has been suggested, or it is in ACVIP guideline. Even not discuss here, sorry, with all due respect, but whatever Committee on Immunization has decided, please follow that, but never criticize, because otherwise that child may be confused. So very good effort, Chetan.
Thank you, sir.
But there is enough evidence, even for whatever governments implement, it's enough evidence, and very soon you will see HPV coming in one dose. Then what you will do? So be prepared, but and try to continue to harmonize. That's a very good.
Absolutely.
So-
very, very
now-
important topic created by Dr. Naveen Bhai, that ideally our aim should be child should get vaccinated wherever it is, in private as well as
We are
in
coming to
government.
that. So, just the question we are not going to discuss. We started from journey from 7, 10, 13, 14, 15, 20, 21. And already PPSC 23 is available. So, new vaccine coming in the market. There are many new. This particular line I drew last presentation at Daman, it was a red line was above. Now it is going beyond. So, I don't know, maybe next presentation this red line will go down and we will have more PCVs. Okay, maybe we will have more PCV with more serotypes, or the similar number of serotypes with a different coming up, company coming up with a different conjugation protein and technology. Yes, we will be discussing in now the crux. The question to all, how do you choose PCV in your practice? Because ultimately, गाड़ी के features दब देख लिए, लेकिन we will say कितना देती है. So
See-
how will you decide which PCV?
Hello. See, most important thing is we as a healthcare provider should be convinced about the science, number one.
Correct.
When we are convinced about the science and the superiority of a vaccine, for me, the cost is the lesser aspect for the parent. If we can convince them, they can definitely come up with that amount and we can give that vaccine very well. So for me, first is science, second is counseling, and third is the cost, which is very, very important. Rest, everyone
Okay,
can definitely.
anyone else? Yes.
So I would put it in the same thing, but in a different way, that like whenever we select a vaccine, what we look at is the safety, efficacy, and the cost. So safety first, even more than the efficacy, I would say.
Yes.
So I don't want anybody to come and complain to me as you have created more problem to my child rather than helping. So any vaccine which is safe is very, very important. But most of the vaccines which are available in the market are going to be safe that way. But when you compare between the vaccines and you know that there are safety advantages, then you would prefer that over a non-safe vaccine. Efficacy important. So all scientific things, immunogenicity data, efficacy data, effectiveness data if you have, which even builds your more confidence on actually taking up that vaccine. And of course, cost is important. But in private practice, the cost goes last. In public sector, the cost is the first, because they have to look at the programmatic things. So that
Yes,
way, of
Umesh.
course, there are so many other points.
One line.
Broader coverage of serotype is important, and another thing is WHO pre-qualification, so safety, quality, and
WHO pre-qualification.
WHO.
Okay. Jaideep.
Yeah, actually, everything has been told. What again is the science? I am not comfortable with a vaccine without 6A. I mean, when you are asking for my personal thing, I am not comfortable. So I convey this. I show the boxes to the parents that this is the vaccine. Now, if they are hesitant, then only I go down to other vaccine. Otherwise, a vaccine without 6A, I will not go with it.
So we need to get convinced about what we want to use it, and then what the way we are presenting to parents, they will be there. So yes, we have to see whatever the serotype coverage, immunogenicity data, effectiveness, non-IPD protection, herd immunity, license indication, and proven reduction in antimicrobial resistance. This is one thing, this is clinical. There can be non-clinical also, manufacturing experience, what is the safety data, ease of use, WHO pre-qualification, as Dr. Unmesh said, supply reliability. Because if we get 2 doses and third dose is not going to be available, then again it's a problem. What is the NIP usage? Because if it is very easy to convince the parents that this has been already been given, particular pneumococcal conjugate vaccine, so that is important commitment to the next generation vaccine. Suppose we know that this particular brand has come with one, which is P7, that has come to say 30, they are going to 20. That really makes a bit of consideration. So you have to look at everything as a whole, and you have to decide. And particularly this particular brand, we know that there are n number of immunogenicity study in children and adolescents, most marketing studies, high risk population, and all these studies are to be considered. So in concluding, I will not read out this. I will say whatever PCV vaccine, use it. That is important, because vaccine they don't prevent, vaccination prevent the infections. Thank you so much, all my audience and my panelists. And if people they want to go and Angelica wants to ask the question, you can continue. Please. Okay. Anyone would like to say? Otherwise, I can just do the freestyle kusti. Because PCV 14, it is given in a government setup because of the data, right? Because government wants that 2+1. So the government endorses that 2+1 and can be given 6 months, 14 weeks, 6 weeks, 14 weeks, and 9 months. But as we discussed, that we are worried more for the individual protection, antibody titer. Yes, serotypes are important. If you believe in cross protection and adding 2 more, you go for PCV 14. If you believe in 6A, what the Jaideep said, and you said 22F and 33F, not that important, or they may be emerging serotype, not as of now, because still our coverage of PCV is not that enough, then you can continue with PCV 13. So, and this kind of things to be discussed. I think that.
Can I answer? Can
Yes.
I answer from audience?
Yes, sir. You can help me out.
Yeah, only, as we tell that the proof of the test is eating pudding.
Yeah.
Similarly, test of vaccine is how much infection is prevented and not serotype covered. Looking at that, even the new PCV10 has a almost similar type of infection prevention. So we can be genuine in giving PCV10 also. Yes.
More serotypes are more taken from the India. That has to be, very clear that it's I think you're talking about serum one, right? So it's a more specific to India, and that, if you listen to them, they will say.
Last comment from Satish Bhai.
What I understand and I know is that the studies are underway, and shortly we will have data for booster doses also for PCV14. No, there is a hesitation because if we use PCV14, we are flouting the
Yes. So I think
literature.
we
But that
discussed-
data is on the way and
we-
it should be available in next few
We are discussing whatever available data, and that's what we have done. Scientifically, we are justifying the session. Thank you so much.